So we'll be discussing about the various aspects of precocious puberty in boys using a lot of these case scenarios, as well as the different aspects of evaluation and management in these regards, which becomes relevant from that perspective. So precocious puberty, as we were discussing, is something which is rarer in children as compared to the adult population, as compared to the female, in compared to the boys will have lesser chances of having precocious puberty. But once they have precocious puberty, there is a greater risk of developing a pathological cause in that regards. And that's something which is important to understand from that perspective. So we have this 5-year-old boy who presented with early puberty, and we can see clearly pubertal development was there. And there was a level of LH and FSH which were not elevated. So usually we expect this to be a central precocious puberty where you have a high level of LH and FSH. And when we found that the LH was low, the first possibility which we considered was obviously in line of an adrenal disorder, which was excluded based upon adrenal imaging, as well as a normal level of 17-hydroxyprogesterone. What was striking was that the HCG level was high, and this turned out to be a HCG secreting tumor. And this really highlights the importance in that perspective of identifying a pathological cause, because this then turned out to be a CNS lesion, a germinoma in the brain, which was producing HCG, causing precocious puberty from that perspective. So precocious puberty in boys is less common compared to girls, but still 1 in 100 theoretically will have precocious puberty. The problem is identification is not that easy, because parents will come to us immediately if they notice any breast development or vaginal discharge. In boys, these changes will not be very, very evident, and that's why it is often not detected at the right time. A significant proportion of them, approximately half of them, may have a pathological cause, which is there from that perspective. So it's rare, but more likely to be pathological as compared to girls, and more likely to have a peripheral etiology as compared to girls in that perspective. All of you can go to have a look at our website, learning.growsociety.in, which has got a lot of informative resources, as well as courses which are there in terms of pediatric endocrinology, including our fellowship course and the pediatric endocrinology for postgraduate course. We do have frequent activities in the form of journal clubs, in the form of discussion PG lecture series from that perspective. There are publications including a basic, advanced, and protocol book, and a mobile app which provides guidance with regards to different aspects of pediatric endocrine disorders. So in this lecture series, we will be covering the pathophysiology, the etiology, and the assessment and management of precocious puberty in boys. And at the end, we will have very interesting Q&A session in which we'll try to cover whatever we have discussed. Major questions which are there in terms of evaluation of precocious puberty. In boys, is it really precocious puberty? If it's precocious puberty, it's central versus peripheral. And finally, what's the cause? So the definition of precocious puberty is very, very clear. So before 9 years of age, if you have any pubarchy or testicular volume increase, this will be a criteria for precocious puberty. Remember that penile size generally is not considered a criteria for puberty. But of course, if there is a significant penile enlargement along with pubic hair enlargement, then you will have to consider that also in that regard. Other pointers could be a rapid increase in height, change in odor, and acne, which may also happen from that regards. Now, we have been talking a lot with regards to how testosterone levels increase and how the testicular volume increase. What we need to remember is that typically with a testicular volume of 1 to 3 ml, the body should have no level of testosterone. The testosterone level rises between 4 to 6, and by around 10, then only you will reach a level of approximately 100 to 200, and then subsequently you will have the mature level. So whenever you're looking at the testicular volume and testosterone level, you can correlate. If you have high testosterone with a testis less than 4 ml, you are typically dealing with a peripheral precocious puberty, quote unquote, CAH will be the most likely scenario. If, on the other hand, TV is more than 10 ml, you are most likely dealing with a central pathology, while intermediate testis could be a HCG producing tumor, a testotoxicosis, or a secondary triggered precocious puberty in the setting of a long-standing CAH, which is there. Now, differentiating central and peripheral is vital because this is important from a therapeutic perspective as well. So the most important thing to look at in a boy with precocious puberty is the testicular volume. If your testicular volume is increased symmetrically, bilaterally, definitely above 10 ml, it's the central precocious puberty. If you have levels which are less than 2 to 3 ml, you're talking about peripheral precocious puberty because of an adrenal cause. If you have intermediate, as Alapan said, between 6 to 8 ml, it will be an apparent LH excess in the setting of testotoxicosis or in the setting of McCune-Albright syndrome and all the disorders in which you will have some enlargement. If there is a unilateral enlargement, we are dealing with a testicular tumor, and that's important from that perspective. Now, what levels of LH should we consider as a marker of precocious puberty? So traditionally, we were talking about LH levels which were more than 0.6 to identify a central pathology. But now with increased sensitivity of the assays, these cutoffs have been shifted to 0.3 and in fact 0.2. So the use of GnRH stimulation test has become less. If your LH is above 0.2 baseline, this is central. Less than 0.1 is peripheral. 0.1 to 0.2, you should do a GnRH analog test in that regard. So we are now shifting towards this 0.2 cutoff because now we have got better assays. Radio assays used to be less sensitive from that perspective, and that becomes important. And what about stimulated levels? So the stimulated levels are more than 5. We generally consider that to be a marker of a central precocity. So central precocity typically has a later onset with concordant development with pubertal testicular volume and a basal LH level being high. Peripheral has an earlier rapid discordant development in the sense the testicular volume is not increased and the basal LH is very low in that regards. Now, once we know which way, we can then go forward in terms of evaluation of the cause. The onset will give you a picture. If you have a very, very early onset, we are talking about hypothalamic hematoma or rarely McCune-Albright syndrome. Later onset typically indicates a form of a central precocious puberty. If there is a rapid and a discordant course, then this could be an adrenal tumor you have to be worried about, or a HCG producing tumor, that is something which you're worried about. If it's a slow orderly pattern, it's more likely to be a central precocious puberty. Neurological features, of course, gelastic epilepsy is absolutely important. So if you have an uncontrolled laughter-like spells, start thinking of a hypothalamic hematoma. If there is history of radiation, trauma, and infection, that can give you a clue of a CNS pathology. Always ask for androgen exposure in the terms of presence of testosterone gel in the house, because that could be something which can be surreptitiously involved. Look at the family history, particularly for the MKRN defects, and features of hypothyroidism should be assessed. Blood pressure examination is absolutely essential because that gives you a clue of 11-hydroxylase deficiency or adrenal tumor. Pigmentation may be a clue towards a simple virilizing form of CAH. And if you have cafe au lait spots, if they are of irregular margin, they will be more likely to be McCune-Albright syndrome, or if they have a regular margin, you can think of a neurofibromatosis as well, and then go ahead and look for neurological examination also in that regards. Now, investigation, the most important one, of course, is testosterone, which will give you a clue whether the puberty has really happened in that regards or not. If the testosterone level is more than 20, this clearly indicates that the child has entered puberty. The best time to do a testosterone is the morning time, because we are talking about nighttime pulses, and herein you will have an elevation in the morning from that perspective. LH and FSH, of course, become important, and usually now basal levels are good enough to give you an idea. So if the basal LH is more than 0.3, or in fact 0.2 now by many of the studies, we can consider this to be central. Otherwise, you can give a GnRH injection in the form of triptorelin, 100 micrograms, or leuprolide 20 microgram per kg, and assess LH after 2 hours. If the levels are more than 5, then you are dealing with a central precocious puberty from that perspective, and then you will get. Now, once you diagnose central precocious puberty in a boy, every boy should have an MRI, as against girls, where it is indicated only if it is less than 6 years of age. While if you're thinking of a peripheral cause, think of adrenal etiology, as Alapan was saying, get a CT scan done, look at 17-hydroxyprogesterone, and then if it is normal, think of 11-DOC to identify 11-hydroxylase deficiency. And of course, bone age is a very, very vital investigation from that perspective. So peripheral precocious puberty, as we were discussing, CT is definitely indicated. Simple ultrasound may often miss it. Look at 17-OHP levels. For HCG tumors, you can do HCG levels, and if they are high, you have to really look for where this tumor is. So get a CT scan of the head, the chest, the mediastinum, and the abdomen to look at the various forms. If it's a testotoxicosis, you can do a genetic study to get the diagnosis. So now if we compare the various forms of precocious puberty, if it's early onset, you're mostly dealing with either a congenital form like CAH or a LHCG receptor tumor, or you can think of a central form. If the testis is prepubertal, then you're dealing more with either adrenal pathology, adrenal tumor, or a CAH, while intermediate testes are giving you an idea of HCG tumor, testotoxicosis or McCune-Albright syndrome. LH above the detectable range is more likely to be central, while it's undetectable in the peripheral form, and from there you can do workup in the form of MRI head, 17-OHP in CAH, testicular or adrenal CT in testicular tumor, screening investigations for HCG tumor, and genetic studies for McCune-Albright and testotoxicosis. So the most important investigation is LH. If it's more than 0.3 or 0.2, you are dealing with a central form. Get an MRI done. Start off with GnRH analog treatment, which we'll discuss subsequently. If it's below 0.1, it's peripheral. Get an adrenal imaging. If it's intermediate, you can do a GnRH stimulation test. In my experience, most cases of intermediate LH levels will turn towards the central cause, because theoretically, if your testo is high, your LH should be 0. This is how the normal response will work. If the GnRH stimulator is more than 5, this is central. Less than 5, this is going to be peripheral. In this case, you look at the adrenal mass. If it's there, you get the diagnosis. Otherwise, you go ahead with 17-OHP, which if it's high, suggests you a CAH, and then HCG, and then finally you can think of a LHCG receptor defect in that regards. So we have a 4-year-old boy with early puberty, and Dhwani, what we can see out here is that the testicular volume is significantly enlarged. In this case, now we've got a LH of 2.2, FSH of 3.2, and testosterone, which is high. What do you think is the most likely possibility in this young child?
Early onset central precocious puberty, you will have to go for neuroimaging. This can be a hematoma, look for signs of neurofibromatosis, which...
So this is a very significant pathology, and what we are seeing out here is that there is a normal tissue of the hypothalamus in an abnormal location, which means it's a hypothalamic hematoma, as you suggested. So this does not require any intervention. You have to give a GnRH analog in that regard. So early onset precocious puberty or central precocious puberty at any age in boys requires a MRI and imaging in that regard. 7-year-old boy with early puberty, testicular volume is 6 ml. There is stage 3 pubic here. Height is not that much advanced. Testosterone is high. It's 54 nanogram per dl. LH is 1.6. FSH is 2.2. What do you would like to do here, Dr. Alapan? Yeah.
Also, the testicular volume is also correlating with the level. But in that boy child, so once you go for the any MRI,
so you should definitely look at imaging. I think this is a big message, that don't get confused that if a boy has beyond 6 years, it will be normal. No, you have to look at the possibility. And what you can see here is that this is a arachnoid cyst. And many of these cystic lesions, as Alapan was talking about, the malformations basically disrupt the signaling pathway, and the inhibitory signals go off, and that's why you trigger precocious puberty. So this was the arachnoid cyst. Again, usually we'll give GnRH analog, wait for any symptoms if they are there, obstructive symptoms. Otherwise, you will just wait and watch in that regards. So 7-year-old boy with early puberty, the testicular volume here was small. So you have a large penis with a small testis. And you find this, that the adrenals are enlarged on the imaging. So what do you want to do, Dr. Sandeep, here?
This is large, and the testes are prepubertal.
Yeah.
So definitely it's a precocious puberty, it's peripheral.
Yeah.
And in that scenario, we have a adrenal which is hyperplastic.
Yeah.
So most likely we are dealing with CAS.
So this is a very clear pointer. You have got peripheral precocious puberty with large adrenals. Your LH is low, testosterone is sky high. So as I said, if your testosterone is high, LH should be 0. 17-OHP is extremely elevated, and this would be a simple case of 21-hydroxylase deficiency. Now, once you start treatment, there will be a risk of developing peripheral precocious puberty. So what happens on started on hydrocort and fludrocort? 6 months later, his testis, which was 1 ml, has become 4 ml, and bone age is progressing. So what do you think has happened?
this case, due to hydrogen, there was decrease in the production of testosterone.
Yes.
So it has activated the inhibitory pathway. It has taken off the inhibitory pathway, and then the central precocious puberty has started.
So this is something which Alapan has talked about. Now 17 OHP is normal, which indicate that your treatment is doing fine, but there's a triggered central precocious puberty. So in this case, clearly you have to think of GnRH analogs, and invariably, I think in all of our cases whom we have found of 21 hydroxylase simple virilizing presenting with precocious puberty, there will be a trigger, which is very common because even if you pick up at 4 years, their bone age often is 11 years by that time. So you stop treatment, start treatment, suddenly the central trigger happens, and you have to be very, very wary about that in this perspective. 5-year-old boy with early puberty, you can see that the penile size has increased, the testicular volume is around 6 ml, it's intermediate. LH and FSH are not elevated. What do you think here?
CT adrenaline is normal, but we will still like to go for HCG that is having 17 OHP levels here.
Yeah, so 17 OHP was normal and HCG was highly elevated. So this is a HCG producing tumor, and this is the case I was talking about. If you find HCG tumor, again, your work is not done. You have to go for localization. And this happened to be a germinoma, and they put in a shunt, and once they gave radiotherapy, there was a dramatic improvement in that perspective. So HCG producing tumor should be considered with peripheral precocious puberty with intermediate size testis in that regards. 6-year-old boy with recent pubic hair growth, he is not tall. You can see height is only 115. His SPL is significantly enlarged, 9 centimeters. Testis is prepubertal and bone age is not advanced. What do you think is happening here, Alapan?
6-year-old boy, hair growth is there. Testicular volume is still in the prepubertal range, and bone age and height is also not progressive. One thing that is striking is the SPL is 9 centimeter, but we don't consider SPL to be that much important in that. So we would like to see the gonadotropin levels in this manner. And
so LH and FSH is low and testosterone is high. So this bone age of 6 years actually doesn't really reassure you. I will be more worried that he has such high testosterone and still the bone age has not progressed. It basically means it's all a recent onset thing. And parents give a history that suddenly he seems to have grown this. So do you think this is something sinister? Yeah, so 17 OHP, which is unlikely, was found to be normal, and CT adrenal showed a large adrenal carcinoma. Remember, whenever we talk about adrenal lesions causing virilization, they usually are carcinomas. So this is a bad prognosis scenario in that perspective. 3-year-old boy with early puberty, height is 106 centimeters, SPL is 9 centimeters, pubic hair is stage 3, and testis is 3 ml. So this is a very, very early onset. What do you think could be a likely possibility here?
Testis is not just reaching the puberty, so
yeah.
It is intermediate kind of testis. So we have to
yes. So we cannot explain the stage 3 pubic hair or SPL of 9 centimeter with this testis of 3 ml. There is something unusual which is here. LHFSH is low, testo is sky high, very, very high, 120. CT abdomen is normal. Now, if you go by our workup, 17 OHP HCG is normal. So what do you think is left here? So either this could be theoretically macunal, right, which will be easy to identify, but more likely to be a LHCG defect. So that's why the receptor study will be there in that regards. Now coming on to the